Hey everyone. So in this video, it's really a follow-up to the last video where we spoke about the importance of appreciating the entire coordinative structure when working with someone experiencing pain. In today's video, we're going to get a little bit more objective within the context of the same case insight that we spoke about in the previous video with the client with left-sided low back pain, and talk a little bit more specifically about our framework and how we would use certain assessments to guide how we load the system, how we load tissues. So in the previous video, we touched a lot more on neural features, but in this video, we're going to speak a bit more about the joint features, or how we can integrate joint behavior to facilitate certain capacities that for us and how we sequence our loading will help us work towards restoring those robust movement qualities that we're ultimately going after. Now, we still need to consider things from a global insight first, as well as a global standpoint first, where we have to ask ourselves the question: how does our system as a whole control all these individual segments, all these individual components when moving the entire coordinative structure? And obviously we're looking at the lower limb, lower midline coordinative structure here, because there's so many ways that we can organize a joint segment to complete a movement task. There's so many ways we can organize a joint segment to solve a movement problem. It's not a case where there's one perfect way, because if there's one perfect way, our system wouldn't be very adaptable. There's not one perfect way because of the sheer amount of possibilities, right? But there are certain capacities that we want our client to be able to express, to ensure or to represent to us that the nervous system has the capacity to offload that workload into the coordinative structure, to allow for a sharing of load, to express that central mechanical flexibility concept that we spoke about in the last video, to reduce the control burden on the nervous system, where it doesn't always have to intervene with what's happening. And what we do here is we use a freezing to freeing framework here. And this is based solely on the work of Nikolai Bernstein, who identified that individuals learn to control these individual segments within the coordinative structure in stages. We spoke about this process in much greater detail in a blog post that we did a while back. We speak about it a lot in our courses as well. But generally, we begin using a freezing strategy first. We'll move into a freeing strategy if we can do that as well. But a freezing strategy really represents a reduction in the degrees of freedom or motion potential. And to really simplify it, a freezing strategy is a strategy to make movement easier to control within a coordinated structure. Right? It reduces that control burden on the nervous system, but it does so at a cost. So we have two options really to freeze. So let's say, for example, when a person's moving, perhaps due to past injuries within a coordinated structure, their nervous system might feel the need to exert more control over the joint segments within that coordinated structure. And one way it'll do that is by locking or freezing the joint movement potential. And we might observe that as an increase in muscle guarding, or an increase in tone around the joint complex, or an increase in co-contractions around the joint complex, which is a very energy expensive strategy to control a joint complex. Or we might observe that as a movement of that joint towards its closed packed position, where there's less variability, because when there's less variability, it's easier to control movement, but it does so at a cost. You become less adaptable. But there are two freezing strategies that Bernstein proposed. And the second is by moving joint segments in the same direction. And from our standpoint, we look at this from a joint rotation coupling standpoint, a rotational joint coupling standpoint, where with each movement in each plane of a multi-joint segment, there needs to be rotational couplings that coexist between joint segments to allow for a sharing of load. Right, and this rotational joint coupling serves as an error dampening mechanism to dampen out perturbations acting on our system from the environment, from external forces as we move. And the best example of this is when someone might be expressing a lot of stiffness or a lot of increased muscle guarding around the midline, for example, and they lose the capacity to dissociate between joint segments, perhaps between the pelvis and the rib cage and the head, where they can't dissociate between all those individual segments. And when they turn their midline as one whole unit, lacking that capacity to dissociate. So it gets the job done, but it doesn't do so in a way that expresses the capacity to share load over a broader surface area. Right? That lack of dissociation or freeing between joint segments doesn't allow for that sharing of load. And this brings us to freeing strategies, which represents a superior way to coordinate joint segments of the body, according to Bernstein, where segments move in opposite directions, representing more variability. So it presents more of a controlled strategy, but it can only be done when our system expresses the capacity to dissociate and handle load during the process. So it's not a case where that has to happen, but we want our clients to express the capacity to allow that to happen. Right. So let's take a look at this within the context of yesterday's or the last video's case example as well. And we look at it a little bit more objectively here too, looking at some objective findings. So let's say that the client during the assessment had limitations in left hip flexion, which you tested in supine with the knee bent. So let's say when you brought that femur through flexion, let's say around the 70 or 80 degree mark of hip flexion, the only way that femur was able to continue moving into hip flexion was if it expressed a strategy like this, where the femur had to abduct and externally rotate to flex further. So ideally, when we're moving that hip through flexion, we want the pelvis to express the capacity to posteriorly tilt to accommodate that femur moving into flexion. And if it can't express that capacity, sometimes what can happen is the femur will move into external rotation and maybe abduction to help drag the pelvis into that direction. So this, and to really, really oversimplify it for the sake of this video, this represents a freezing strategy. So it gets the job done with the pelvis and femur moving in the same direction, but it doesn't represent a freeing or dissociation capacity that we ultimately want the client to be able to express to allow for a sharing of load. So ideally, to reflect this dissociation capacity, we would like to see the femur express the capacity to maintain its position in the sagittal plane as we move that through hip flexion, and for the pelvis to posteriorly rotate, where the femur will be able to relatively internally rotate relative to the pelvis. So we need that hip internal rotation to achieve full hip flexion. And what we also might see as well is limited left hip internal rotation as well, as it's classically measured with the hip at 90 degrees of flexion as well. So in this client with if you remember back to the last video, with a gradual onset of left-sided low back pain, that's, remember, worse during and after activity, and also with a history of ankle sprains on the left side, we need to consider that potentially that increased muscle guarding or increased protective tone that might be potentially limiting these joint motions proximally, and maybe secondary to the lack of distal loading or the capacity to handle stress and load and forces distally at the distal end of the segment. So we still certainly want to restore this proximal dissociation capacity, but we need to think about it from a global standpoint as part of a sequence to ultimately allow the system to share load across that entire coordinated structure to develop a more robust coordinated structure. So one of the many strategies that we may use here, which we'll actually go through in the next slide, will be to bias that pelvis towards a posterior pelvic tilt while we drive internal rotation distally. So we're essentially trying to create that dissociation or that freeing strategy proximally, but while we simultaneously load the tissues at the same time. And this is one of the big things that people miss, is that they get into all these positions, but they don't load the system appropriately to generate a learning effect. Right? This is often the component that's missing. We need sufficient loading to really challenge the nervous system, because we need to challenge the individual with these strategies to try and drive more robust movement behavior. Okay. So the intention here is to facilitate more proximal dissociation capacities, or freeing between the pelvis and the femur. But what we can do to facilitate this is facilitate a freezing strategy more distally between the femur and the tibia, to ultimately facilitate this global internal rotation, right, throughout the limb distally, while we facilitate more a posterior pelvic tilt proximally. Right. So we're setting up here in a supine position, with the hips flexed and the heel up on a chair, with the hip flexed around 70 to 80 degree mark, where that individual may have began to abduct and externally rotate the hip as you were moving it through hip flexion. Right. So here you'll have to imagine that the right leg is the left leg in this example here. So the reason we're we're flexing that opposite limb towards the chest is to make it easier to bias that pelvis as a whole towards more a posterior pelvic tilt. And what we can also do as a therapist here is help to drive that tibia into rotation through the foot distally, and also allow for that knee to deviate medially as well to bring that femur into adduction and internal rotation. But we also ultimately want the client to actively assume this position as well. So we're trying to drive that tibia into internal rotation, drive that femur into internal rotation as the pelvis biases more of a posterior pelvic tilt, right? And what we want to do here is actually start with an overcoming strategy where we're telling the client that we want them to gently fight that heel, the inside portion of the heel, into the chair, straight down to the chair, and maintain that constant but gentle fight into the chair where we're biasing the tissues on the posterior thigh towards more concentric and isometric dynamics first, just to the point where they can allow for that pelvis to gently unweight from the ground or from the table, to almost to the point where it's hovering. But we want them to continue with the intention of gently fighting down into the chair at all times. Okay, we want them to do this over a longer duration. So we're not just doing this for a 3 to 5 second hold or a 10-second hold, because that's not really going to challenge the nervous system enough to generate a learning effect and restore the capacity to handle stress and share load. So it's really important to consider that. We want to keep the intensity low with the level of pressure, but sustain that loading with relaxed breathing for at least a minute or even up to 90 seconds. So if you have to decrease the amount of intensity through that heel to get a longer duration, we will do that as well, right? But we have to remember that this is one of many strategies that we might use, but we just wanted to show you here how we might use objective markers to guide how we're loading the tissues, particularly how we might organize the behavior of the joints during loading, because it's really important that we use the assessments to guide more focused treatments, because it also allows us to have a much better conversation with the client and allow the client to come to their own conclusion as to why we're doing what we're ultimately doing to restore certain capacity. So some potential regressions here as well might be to bring that tibia and femur back into the sagittal plane, or to allow that femur and tibia to express more external rotation as well. Right, so we're biasing or facilitating this global external rotation across the entire coordinative structure, but it still gives us a platform to allow for load to be shared across the system. All right. What we could also do as well is regress as well to put load through the proximal tissues here as well, around the lower midline, for example, or around the hip tissues as well, instead of into the biarticular tissues first on the posterior portion of the thigh through the hamstrings. So lots of things to consider here, and hopefully it gives you sort of a better insight into what guides our interventions and the framework that we like to use during our assessment. And in the next video, what we're going to do is we're going to go into a little bit more detail about the more muscular features and what strategies we might use to shift that load even more distally into the foot and the ankle to help restore more distal isometric behaviors and ultimately help facilitate an environment where the low back and the hip can express the capacity to be a little bit more adaptable and express more freeing, more dissociation behavior.